Thank you, Martin, for the introduction. I am going to speak this morning about something that's supposed to be very translational, so lab-based, but close to clinic, and something we're trying to apply into the clinic. So I've titled the talk, Translating Bladder Cancer Genomics into Clinical Practice. And I would say up front that there have been a lot of collaborators in this, and I'll highlight them on my last slide. But most of the genomics has actually been done by others, including Ewan Gibb, who's a collaborator at a local company. So the context is that, if you look at the amazing prostate cancer research that happens in Vancouver, it's really indicative of the scenario around the world that bladder cancer has been playing catch up for a long time. We've been the ugly duckling that has a very poor sort of molecular basis of our understanding of the disease, and therefore also few novel treatments, unlike prostate, kidney, and so many of the other cancers. And up until recently, this whole era of targeted therapy had more or less bypassed bladder cancer. But in the last sort of 7 to 10 years, there's been a huge boom in bladder cancer research. I want to touch on some of the topics. Now, I knew Andrew McNeely was going to be here, so I had to include one slide about the differences between non-muscle invasive bladder cancer and muscle invasive, because I know the peds guys don't get out much, and so they don't know this anymore. But I'm going to be focusing in on muscle invasive disease. I'm going to completely ignore the non-muscle invasive disease, even though there is more and more coming out in non-muscle invasive disease. I'm going to focus mostly on using RNA expression to classify muscle invasive bladder cancer, and there have been recent papers on doing the same to classify non-muscle invasive disease, but for the sake of time, I'm just going to focus on muscle invasive. And in particular, I'm going to talk about molecular subtypes of bladder cancer, which has really changed how we think of bladder cancer. From that, I'm going to tease out the neuroendocrine-like subtype, which is one of the molecular subtypes of bladder cancer. We've done a little bit of exploration in that field that I'll tell you about. And then I want to focus in on how subtyping and other markers can be used to predict the response to neoadjuvant chemotherapy, so cisplatin-based chemotherapy. And then at the end, I'll just explain a story about how it can predict upstaging from TUR to cystectomy, and how we might use that in clinical practice. So subtypes, I'm going to have to show some heat maps here, so get ready. The subtyping it really hit mainstream in 2014 when the Cancer Genome Atlas paper came out in Nature. They characterized bladder cancer, muscle invasive bladder cancer on different platforms, including RNA, DNA, epigenetics, and other platforms. And they divided bladder cancer into 4 subtypes. The notion of classifying bladder cancer based on RNA expression, however, goes back as far as 2013. The group around Torben Orntoft in Aarhus, Denmark, has been leading the way in many different aspects of bladder cancer biology, as they still are. But a true classification, so a taxonomy of bladder cancer, was reported in 2012 by the group in Lund, Sweden. And it's funny to see how this unfolded. In 2014, the TCGA paper was published, and then there were 2 other papers published, and all of a sudden people were describing about new classification, even though it really had been reported at least in 2012. And so I think in retrospect, this group in Lund got more credit than they initially did. This paper down the bottom left is from the group at MD Anderson, David McConkey's group. And they really made subtyping interesting, or it captured people's attention because they put it in the context of response to chemotherapy, which is what I'm going to talk about predominantly. So it wasn't just an academic exercise, as I think people thought whenever the Swedish group reported. And the group down here in the bottom right, Billy Kim's group in the University of North Carolina, they drew immediate parallels to the breast cancer world, where subtyping had been established for 20 years and actually is clinically relevant in daily practice. So the combination of these 3 papers, all within a month of each other, immediately put molecular subtyping of bladder cancer on the map. And the basis of it really is quite simple. All of the subtyping schemes that we have at a higher level divide bladder cancer into luminal and basal. And luminal bladder cancer just means that the tumor has a gene expression pattern that is similar to the well-differentiated luminal urothelial cells, so to normal urothelium, the intermediate and umbrella cells. So the things like uroplacans, for example, that we associate with mature urothelium. The basal bladder cancers, on the other hand, have a more immature, undifferentiated gene expression pattern, similar to the basal layer of the urothelium. So they may be more stem-like and have genes. For example, you see here EGFR is a common basal gene. And so at the simplest level, this is the UNC classifier, and this is the heat map I was warning you about. If just a word on heat map. So each column is a patient and each row is a gene. The gene names are all over here. And you can see that these, if you take this cohort of patients and you line them up by just the genes listed, these patients here have very high expression of this group of genes and low expression of this group. And this group of patients is the other way around. So the UNC divided patients into basal and luminal as just two classes. And I'm going to come back to this because we actually use this classifier. It's a very clean classification. There's very little, just the methodology, how they did it. The patients were clearly one or the other, and there wasn't a big gray area. They subsequently added a third group to their classifier. The MD Anderson classifier, you'll again see that there's patients up here who have, very clearly high basal and not much of the other. And then these ones over here have high luminal and not much of the other. So we have basal tumors, luminal tumors. But this group at the bottom has this group in green here. They don't have much basal, they don't have much luminal, and they have a lot of these genes, which are all related to fibroblasts and smooth muscle cells. And so these are stromal genes. And this group is called the P53-like category. It has nothing to do with P53 mutations. P53 is a gene of sort of a marker of senescence. So active P53 expression indicates a relatively senescent group of tumors, which is important. I'll show you later for response to chemotherapy. And so we have a two-group classifier, three-group classifier. The TCGA was initially 4, became 5. The Lund classifier has varied over the years. It was a bit of a mess. Everybody had their own scheme. And so last year, most of the people involved in subtyping got together and developed a consensus classification. So consensus meaning that everybody threw their data together and they agreed on methodology, and then they agreed on names of the subtypes. And so this consensus classification has 6 groups, and this looks a little bit complicated, but about half of patients are luminal in some way, and there are 3 different luminal groups. The most important, most prominent are the luminal papillary tumors, and a lot of non-muscle invasive bladder cancer is also luminal papillary. All of the luminal tumors, one of the key features is that they have overexpression, sometimes amplification of PPAR gamma. The luminal papillaries are driven by FGFR alteration, so the FGFR3 alteration. So these are tumors that we think should respond to erdafitinib and other FGFR targeting therapies. They also generally have the best prognosis, and I come back to them at the end because they are the ones that are least likely to be upstaged at the time of cystectomy. So upstaged from non-muscle invasive or T2 up to T3, T4. Luminal unstable is interesting because it has a high, so unstable means genomically unstable and has a high rate of mutations, which in bladder cancers is typically actually a good thing because they tend to respond better to therapies, including immunotherapy and potentially chemotherapy. The luminal non-specified are just interesting because the mycopapillary variant that we hear a lot about as an aggressive form of bladder cancer fits into that subgroup. And then the non-luminal ones are a bit of a mix. The stroma-rich group is much like the P53-like group that I talked about, where they have high expression of genes associated with fibroblasts, smooth muscle cells. Basal squamous is the biggest group, and I'm going to come back to it because it appears to have the biggest benefit from chemotherapy. As the name implies, it often has squamous differentiation, and so morphologically you can sometimes recognize that, and it is more common in women. It is by itself, without treatment, aggressive and has a poor prognosis, but as I said, it tends to respond to treatment. And then a small category over on the right-hand side here, only 3% are the neuroendocrine-like tumors. And I'm going to go into them in a little bit more detail. So the group from Lund and the TCGA group are the first to describe, within a large cohort of conventional urothelial carcinoma, so morphologically conventional urothelial carcinoma, there were patients who had, or tumors who had gene expression that was highly neuroendocrine. And so the idea is that somewhere between conventional urothelial and morphologically neuroendocrine, you have these tumors that look urothelial but have neuroendocrine gene expression, that there's some kind of transition going on. And another heat map, and let me just explain this one to you. So this is the TCGA cohort of 400 patients. And in dark blue are the patients that we developed a neuroendocrine-like classifier that was relatively strict, or very strict. It identifies only patients who, at the bottom, they have this high expression of neuroendocrine genes or neuronal genes, but they're really missing the typical gene expression of the other subtypes, so basal, luminal, et cetera. The light blue is the TCGA classifier, which is a little bit broader and includes some patients that you might otherwise, for example, here call basal, or over here you might call them luminal. But in any case, you find a very small group within the larger cohort of patients with neuroendocrine-like gene expression, and they do very poorly. So this is a survival curve, and you can see that the neuroendocrine-like ones have very poor outcomes. All patients essentially have died within just over 2 years. And so we have various cohorts that we've looked at in other contexts, and so we looked for the neuroendocrine-like tumors in these cohorts. And again, you can see just this small, each column is a patient. So you have just a few patients here, 3 patients in our neoadjuvant chemotherapy cohort, 8 patients who had cystectomy only, and 9 patients who had chemoradiation. This is a collaboration we did with the group at Massachusetts General Hospital, which does a lot of radiation. So in all cohorts, you find a small number of patients. And we were able to actually get some tissue from some samples. These are multi-center projects, and we had the RNA that we had done in different contexts, and we had to then go back and see if we could actually get tissue from some of these patients. And we got tissue in 8 neuroendocrine-like tumors, and then 4 just standard conventional morphologically neuroendocrine as a comparison. And we looked at protein expression. So these are the truly neuroendocrine tumors, and you see strong expression of things like synaptophysin, chromogranin A, CD56, as you would expect. Some heterogeneity. This first patient, for example, doesn't have much except the ENO2. But we had the 8 neuroendocrine-like that at the protein level, so not only RNA, but also protein level, have very similar expression of these markers, perhaps with the exception of chromogranin A, which is negative across the board, more or less. And so we looked at the survival outcome again of these patients, and you can see the neoadjuvant chemotherapy cohort. There are only 3 of them, but all 3 patients did dismally. In the radical cystectomy cohort, they did poorly. Again, all patients had died around the 30-month mark. Very interesting, the patients in the chemoradiation cohort actually didn't do that much different than the conventional urothelial cohort. It's a bit of an unusual cohort because there were 9 out of 136, so a very high proportion. And we think of neuroendocrine as likely failing distant, in a metastatic distant location and not in a local location. So it doesn't necessarily make sense, but it's something to explore in the future. There is the group from the TCGA actually took their classifier. So these are the 5 groups in the TCGA classifier, and the neuronal is the smallest group, and they applied this to clinical trial data from the Invigor 210 trial, which was one of the first trials that looked at a PD-L1 inhibitor, so atezolizumab, in the second-line metastatic setting, urothelial carcinoma. And they looked at response, complete response, partial response, stable disease, progressive disease by subtype. And you see that the neuronal patients, all of them responded. So 8 out of 8 had a complete or partial response, whereas for the other subtypes, it was between 18 and 38%. So this, caught their attention. They also had particularly good overall survival. I think there's some skepticism in the field. There have been other data sets that have come along since then that show that neuronal tumors don't necessarily do any better. And there's no indication in any other cancer location that neuroendocrine tumors do better with immunotherapy. So I think small sample size, and this is have to see if that's real or not. So let's move on from how so subtyping in the context of neuroendocrine selects out one group of patients who have a different biology than the rest and very poor prognosis, and there's a need there to understand it better and develop better treatments. But let's look how subtyping can predict response to neoadjuvant chemotherapy. And so for everybody in general, the issue with neoadjuvant chemotherapy is that we have relatively good data that it improves overall survival, a modest but significant improvement in overall survival in patients with muscle-invasive bladder cancer. There are multiple trials, there are multiple meta-analyses. There's no question about the data, yet it's not used widely. And it's probably because only about 40% of patients, those 40% have a major response, are actually going to benefit from it. The other 60% who are left with muscle-invasive disease after neoadjuvant chemotherapy potentially have all of the side effects and the delay in surgery without any benefit. And so I think a lot of urologists are not really that comfortable with it, and it's not used widely around the world. So one idea for overcoming this gap is that if we could select patients who are likely to respond, we could give them chemotherapy, or if we're able to select those who are unlikely to respond, we could prevent them from getting chemotherapy, and that would improve uptake and generally improve patient outcomes. And so I had mentioned that the MD Anderson group, when they reported on their subtyping model, they, in their first publication, also highlighted the correlation to response to chemotherapy. And this is the data that they showed. They had 3 small cohorts between 20 and 40 patients. They had their 3 classes, basal, P53-like, and luminal. And they're just looking at pathologic response to cisplatin-based chemo. And you see that the P53-like tumors in the middle rarely respond, whereas the others have an approximately 40 to 60% response rate. And so this is very interesting. This was a potentially useful clinical marker, but only in small cohorts. So we set out with a multicentric cohort to see if we could validate this. And by the time we were up and running, it had, of course, expanded that we wanted to look at all of the subtyping models to see how well we could predict response to neoadjuvant chemotherapy and see if one performed better than the other. And at the time, I had a fellow, Roland Seiler, coming from Bern, Switzerland. So he brought some tissue with him. We actually hosted the International Bladder Cancer Network meeting in Vancouver, and there was representation from Seattle and UC Davis and Rotterdam at the meeting. And so they all ended up just, serendipitously contributing. We had a fellow, James Douglas, from Southampton. So we put together this piecemeal retrospective multicentric cohort. And we had 223 specimens prior to chemo as a discovery set and 82 as a validation set. The larger numbers here were used to develop and validate the classifier, and the smaller numbers, we only use the cisplatin-treated patients to look at efficacy and predicting response. But looking at one cohort alone treated with chemotherapy doesn't necessarily tell you about the benefit of chemotherapy. You need a cohort that's not treated with chemo. And so we went to publicly available data sets for that, the TCGA actually has 400 patients. At the time, it was unclear if some patients had been treated with chemo, so we reduced to the ones that we knew had not been treated. And then there's a group from MD Anderson and Lund. So we had almost 500 patients not treated versus about 300 patients who had been treated. The other thing to recognize about these classifiers is that to classify a patient with one of these subtyping models, you actually need a whole cohort. You run the clustering, the classification, and then you can tell for any given patient what subtype they belong to. But if you're doing this in clinical practice, you need to apply the classifier to an individual patient, a single sample classifier that you can use for the patient sitting across from you in clinic. So together with the group at Decipher with Ewan, we developed, actually it preceded Ewan, but we developed a single patient classifier. And we ended up using the UNC classification that divided into the very clean division that I mentioned about into luminal and basal. But they had also subdivided their basal into just basal and claude and low, which is a group that's very high immune infiltration, is very mesenchymal. And we also subdivided the luminal into two of the groups from the TCGA classifier because we saw real differences in outcomes. And so these four classes here, claude and low, basal, luminal infiltrated, which is it's like the P53 like, and luminal. And you see here, this is a survival curve for the patients not treated with chemo, so the ones in the public domain. And the important thing here is going to be the comparison to what's over here. You see that luminal patients do very well. And I had commented previously that luminal papillary especially are the ones that are unlikely to be understaged. So they're unlikely to be upstaged at time of cystectomy. And so you see these consistent trends across all data sets. So luminal is generally a positive or a favorable group. The other groups are all more or less similar. They had relatively poor outcomes without chemotherapy. Now, when you look at the cohort that's treated with chemotherapy, the most important thing is that the red line, the basal tumors, now pop up and they're very similar to the luminal tumors. Whereas the other two, it looks like they stay more or less the same, but there actually is some benefit in the gray line as well, which are the claude and low tumors, which are a subset of basal, really. And you can see this with the actual numbers. The luminals are identical. This is 3 years overall survival, around 75% with or without chemo. And the luminal infiltrated actually go down a little bit. I mean, you have to be very careful with these comparisons, multiple cohorts, different studies, et cetera. But from about 60 to 50, basal goes from 50 to 77, claude and low, 43 to 58. So you see differential impact of treatment in different subgroups. So these are truly predictive biomarkers.
Peter, where is P53 in that? Is it in claude and low or is it in the basal? I can't remember.
P53 actually, so P53 has sort of been revised by David McConkey, and so half of them are basal infiltrated, which would be similar to claude and low, and half of them are luminal infiltrated. So they sort of divide the luminal basal. So now, what are the limitations here? I mean, it's a good story, but it would be wouldn't be honest to say that there aren't some limitations to this. First of all, in the neoadjuvant chemotherapy setting, we know that pathologic response to chemo predicts overall survival. Yet in this data set, even though we're able to predict overall survival, it did not correlate with pathologic response. And so that's a bit of an anomaly that we haven't been able to explain. There's a lot of talk about intratumor heterogeneity with respect to subtypes. So is one area basal and another area right next to it, maybe luminal infiltrated. And various people have looked at this, and in general, especially the group in Lund, has suggested that the heterogeneity is not a big problem. There is some heterogeneity, but I think that is still an unsolved problem. And then there have been two more recent publications. There's a third one actually now in bioRxiv, sort of pre-peer review, that questions this, and they suggest that there's no real difference by subtype. But what I would say in response to both of these other publications is that there's no comparison group. So there's no group not treated with chemo to see what the benefit of chemo is. So I think it's still something that the community is trying to figure out. So in the realm of molecular predictors for response to neoadjuvant chemotherapy, I wanted to move also beyond molecular subtypes and talk a little bit about the Coxswain model, which is also based on gene expression. It's complicated, but it's interesting because there's already been a clinical trial looking at this, and then some very interesting specific individual gene alterations that predict response. And so the Coxswain model, if you bear with me here for a minute, so this was developed by Jay Lee and Dan Theodescu at the University of Virginia. And Dan is a urologist who trained at the University of Toronto. He's Canadian. And they basically started with the NCI 60 panel of cells. So this is 60 well-established cell lines. None of them are urothelial, but still well-established. And there's a bank of data. So first of all, you know the gene expression data for all these cell lines, and you know their response to many different drugs. And so the basis of this is correlating gene expression patterns to response to any individual or combination of drugs. They made it more bladder specific by adding in both patient expression data, so real patient tumor expression data, as well as bladder cell line data. And black box, there's an algorithm to match gene expression to response to treatment, and they have validated it in a few different cohorts, retrospective cohorts. Also, they did it in a clinical trial cohort. And if you see on the right side here, for example, so the Coxswain score is supposed to predict likelihood of response to whatever chemo you're thinking of. And so patients who were downstage with neoadjuvant chemotherapy, this was an MVAC trial, those who were downstage actually had been predicted with a higher score to downstage compared to those who were not. And if you look at survival curves, again, those predicted to respond did much better than those predicted not to respond. So this is the type of data that they had when they designed this SWOG trial, so 13, 14. And this is called the Coxswain Trial because of the Coxswain algorithm. And there was a lot of excitement around this because it was a trial built specifically around biomarker validation and discovery of new biomarkers. And so it was your typical muscle invasive bladder cancer cohort, so node negative, muscle invasive disease, cisplatin eligible. Patients were randomized to receive either gemcitabine and cisplatin, which is of course what we usually do in BC and most places in Canada, versus MVAC, and this was mostly dose-dense MVAC, which some places in the US prefer. And they then underwent cystectomy, and then you had the pathology before from TURBT and pathology afterwards. And the idea was it wasn't powered to compare the two chemotherapies. They just wanted two different chemotherapies involved, so they would be testing for two different combos. And the endpoint was really to predict T0, so no residual disease, or just non-muscle invasive residual disease, with collection of all these biospecimens along the way. And so this is actually now being published. I need to update this slide. But basically it failed. And I'll just walk you through this table. So there's a Coxswain score for GemCis and a different score for dose-dense MVAC. And so if you look at the patients treated with GemCis, so this is the arm over here, and you look at either T0 or non-muscle invasive disease, you see a hint that the score is working to predict T0, but the p-value is 0.1. So odds ratio 2.6. So it looks like maybe if you had a bigger cohort that the GC score might predict response to GC, but it didn't as this trial was powered. For dose dense, it completely failed. So odds ratio is around 1. And now if you apply the GC score to both cohorts, so now you have a bigger sample size and you're predicting non-muscle invasive disease, then it is statistically significant, odds ratio 2.3, but this is not what the trial was designed for. So there was a lot of humming and hawing initially, but I think in the meantime, the Coxswain model has been put to rest. And I don't think this is going to be carried forward. So let me talk about some of the genomic alterations that predict response to chemotherapy, and you will know that there are multiple different insults that can lead to DNA damage. And normally cells also have mechanisms to deal with that DNA damage. And one of them, of course, is DNA repair. And cisplatin is a chemical exposure that leads to DNA damage. And if the cancer cells are deficient in DNA damage repair, of course, the cisplatin you would anticipate would be more effective, and the tumors would undergo apoptosis. And there's actually some evidence of this. So the first report, interesting, also in 2014, from the group at Dana-Farber, so Ellie Van Allen has done a lot of prostate cancer work, but also some very nice bladder cancer work. And they took two groups of patients, one cohort, but just 25 responders, 25 non-responders. The responders were T0, the non-responders had muscle-invasive disease, so a very nice dichotomous split. And they were looking at some typical genes like P53, RB1, and how did those mutations correlate to response to chemo. And what they found at the bottom here, so the responders, 25 responders, 9 of them had a mutation in ERCC2, and none of the non-responders did. And ERCC2 is a excision repair gene, so a DNA damage repair gene. And so it makes biological sense. Clearly, it's not the only thing driving response, since we have patients without ERCC2 mutations who responded, but it is a very interesting finding. And then there's a group from Fox Chase. They had a cohort of patients. You can see here 48 patients. 10 of them had ERCC2 mutations, and their survival was essentially 100%. So no patient with ERCC2 mutation died within over 1,000 days, over 3 years. They did have a couple of non-responders with ERCC2 mutations, but they still did very well. The group from Fox Chase at the same time were looking at their own panel of genes, and they had two different trials, single-arm phase 2 trials. One was looking at dose-dense MVAC, and one was looking at dose-dense GEM-CIS. And so they used the first cohort as a discovery cohort. It's about 34 patients. And the second is only 24 patients, but still 2 separate cohorts, discovery and validation. And they found that if any one of these 3 genes were mutated, patients, again, had 100% overall survival compared to wild type. And in the validation set, it was very similar. Now, ATM is a DNA damage repair gene alteration that we recognize and has been talked a lot about recently in prostate cancer. RB1, of course, is much more than DNA damage repair. Still, the correlation was seen. Neither of these groups really looked at the predictive value of these mutations. So if you had one of these mutations, what was your survival regardless of neoadjuvant chemotherapy? And so we did this in the TCGA cohort. And this is for any one of the 3 genes. So the 4 genes, the 3 Plimac genes and the ERCC2. And you see in the absence of chemotherapy, there's no difference in survival. Now it's interesting to look at the literature, and everybody does either DNA or RNA, and no one has crossed that divide. We have tried, we're still working on this. We've done this with Colin Collins. And so we looked at our 35 responders and 71 non-responders, and it's a subgroup of the patients that we did the subtyping on. We don't see any difference in ATM. We do see a similar difference in ERCC2 mutation rate. RB1, there's a big difference. And the FANC-C, there's only one mutation on one side, so it's hard to say. So it more or less supports what's in the literature. And if you think now that you could combine, so if you're able to combine subtyping and these individual mutations, where would it leave you in selecting patients for chemo? And so you can see in red here is the basal subtype. So we want to take all patients with basal subtype, potentially. That's what we're saying, that they benefit the most from chemotherapy. And then if we took in the other subtypes, the patients who have one of these mutations, you end up with approximately 50% of patients in the TCGA who are marker positive, so marker for prediction of response to chemo. And if you combine, actually, I think it's got out of order, but if we look at the ability of the DNA damage repair mutations, sorry, did I skip something? No. DNA damage repair mutations to substratify subtype, and here we put, just for the sake of sample size, the claudin low is considered a subset of basal, so we put these two together, and we put the luminals together, and you can see that presence absence of a mutation does substratify the basals. It does not necessarily substratify the luminals, however small sample size. But again, this comes back to the combined marker. If we look at subtype and DNA damage repair gene, if we look at the TCGA cohort where patients were not treated with chemotherapy, we do not see a difference between marker positive and marker negative. If anything, the marker positives the marker negative are a little bit better than the marker positive, but they're the same really. And in our neoadjuvant chemo cohort, then the marker positives are clearly better than the marker negative. So you can imagine combining both sets of markers is the point here. And so it's interesting to ask, this is the SWOG trial, SWOG 8710, that has really established neoadjuvant chemotherapy in our practices. And if you were able to apply a biomarker to this, what would it do to outcomes? And so in the top, we have patients who had cystectomy, chemo followed by cystectomy, and the bottom are the patients who had cystectomy alone. Now, if you took out the patients who are marker positive and treated them with chemo plus cystectomy, of course, you'd expect this line to move way up because you're selecting for responders. But at the same time, the marker negatives ones, you would expect to move down. And I think there is a risk that we could be harming these patients by treating them with chemo and delaying surgery. So this is just speculations, not based on data. And so the question is, what are we doing with these subtypings or with these predictive models to validate them? And it's interesting to see how the medical oncologists are using this to design trials to preserve the bladder. And I'll show you an example. And the urologists are using them to design trials to avoid, or I shouldn't say avoid chemotherapy, but select for chemotherapy. And so there are 3 trials like this one. This is a cooperative group trial through the Alliance. Gopa Iyer is a medical oncologist at Memorial Sloan Kettering. And they are treating muscle invasive patients with dose dense gem-cis. They can also have other chemo, but this is what they designed it around. They are looking for any one of these 9 DNA damage repair genes, so mutations in these genes. And you see they're different than, so the RB1 is not here, ERCC2, ATM, and FANC-C are, plus other genes that have not been well validated, I would say. And they're looking at, so they expect approximately a quarter of patients, or a quarter to a third, to have one of these mutations. If they have a clinical complete response to chemo, they get to keep their bladder if they have a mutation. If there's any T1 or greater disease, they have a cystectomy, and if they don't have a mutation, they have a cystectomy. So the idea is, can you preserve bladder in patients have a complete clinical response, knowing that it's very likely that these patients are going to do very well if they have one of these mutations. So that trial is well on its way, as are 2 other similar trials. Josh Meeks is a urologist at Northwestern, and I've been working with him and Seth Lerner and a couple of others on a trial that uses subtyping to guide neoadjuvant therapy. And again, it's a similar patient population. They're cisplatin eligible, so that we can give them the standard of care neoadjuvant chemotherapy. But we would divide into luminal papillary, basal, and the rest, and partly the rest because we don't really know what to do with the rest. And I told you that luminal papillary is often driven by FGFR3 alterations. So we would, and they're unlikely to be upstaged to extravesical extension at time of cystectomy. So we would compare an FGFR inhibitor versus neoadjuvant chemotherapy before cystectomy. For the basal, there's reason to think that immune checkpoint blockade would work. So we'd compare that to the standard of care. And for the others, we'd actually combine chemo and immunotherapy. And this is a type of trial where you could add in other treatments as you go along, as we understand the biology more and have more compelling reason to try something else. So that's just a concept. We've also looked to see if molecular subtypes predicts response to immunotherapy and here trimodal therapy. So trimodal therapy is radiation plus chemo plus maximal TURBT in patients with muscle invasive disease. And this is, again, something we did with the group at Massachusetts General Hospital. And if you look at just the cohort by themselves, again, it's hard to tell if you're looking just at one treatment modality. But the conclusion here was that subtyping doesn't really predict response. But I told you previously that the luminal infiltrated group does quite poorly with cystectomy alone and with neoadjuvant chemo. So the fact that they're up here with the others makes you think, well, maybe they are benefiting, especially from trimodal therapy. And if you look at immune scores, and part of the luminal infiltrated does include immune infiltration, although it's also stromal infiltration. But in the patients treated with trimodal therapy, if they have highly immune tumors, they do better than the rest. This is the first quartile versus the other 3 quartiles. Whereas in neoadjuvant chemotherapy, it's the other way around. The more immune tumors do worse. So again, the potential to select patients for treatment or select treatments based on gene expression, although this is not specifically subtypes. And for immunotherapy, this is something we did together with Andrea Necchi in Milan, who's done a trial on neoadjuvant pembrolizumab. And again, looking just at immune gene expression, patients who after pembrolizumab have no residual disease have a higher immune gene expression compared to those with residual non-muscle invasive and muscle invasive disease. Yeah, with chemotherapy, we don't see that. They're sort of all awash. So the idea is that immune gene signature could be predictive in this cohort. If we look at the subtyping, you can see here is interesting, the claudin low in gray and the luminal infiltrated in blue, which didn't do very well with neoadjuvant chemo in our prior cohort. They actually do very well with immunotherapy. So small numbers in each individual group, but hypothesis generating. So you can imagine how we could use all of this in clinical practice. And I would say we cannot yet use it in clinical practice. It all needs to be validated in prospective trials. But you can imagine that patients with basal tumors would be prioritized for neoadjuvant cisplatin-based chemo. Patients with immune-enriched tumors who are at low stage will get trimodal therapy. Low stage just because we know smaller tumors do well with trimodal therapy. If they're higher stage, then probably would benefit more from the systemic therapy and immunotherapy, neoadjuvant immunotherapy could be an option. And then the other subtypes that don't appear to benefit from neoadjuvant therapy should go on to immediate cystectomy. So I'm actually going to skip over this last section for the sake of time and just jump to the my conclusion slide here that I think the molecular subtyping, we would like it to be clinically relevant, and it's heading in that direction, but I don't think we can actually conclude that it's there yet. But it does give us a very important framework for translational research as well. If we're looking at a pathway or a gene in bladder cancer, the first question we often ask is, how does it correlate with molecular subtypes? And any given marker or process may be relevant in one subtype, but not another. I think the neuroendocrine neuroendocrine-like story just shows you the power of molecular classification and how we can select out individual groups that may need to be treated differently and that we really need to study specifically to understand their biology. I highlighted that the basal subtype has greatest benefit from chemo. I skipped showing you the data that shows that luminal papillary probably doesn't need chemo because they have a very low risk of upstaging and are probably well managed with surgery alone. And then I think it's exciting to see all this work head towards clinical trials to see if we can actually validate this and introduce it into practice. And then I'll just thank all the people. I think I've had some very strong fellows over the years who have helped. I give a shout out to Alex, who's gotten up early to listen to this talk, and Ewan Gibb, who is a genomic scientist at Decipher, which is a local Vancouver company. And he's done a lot of the genomic analysis in this, and then a lot of tissue and collaboration from around the world.